the general public became sort of accustomed to these like miracles. The challenge is that the nature of disease has changed. Now, chronic disease is a function of biology and society. Some of it is just man-made. It's a product of something that we have done that creates a disruption in our biology. Social problems have social solutions. Those same things we can use to bring us back to a physiological state, to correct that aberration.
That's so important and missed out on in modern medicine is this exact concept that organisms are not just biology. It's extremely significant to talk about the gene crossed with the environment that our ancestors were adapted to. Before the modern era, the kind of environmental exposures were dramatically different.
Healthcare requires a really radical shift, but I'm very optimistic that we can get there.
We need that optimism because that is a radically different way of practicing medicine.
The golden opportunity that medicine is missing out on, that, hey, yes, I do these things, I can prevent a lot of disease. The magic is that same thing you can use to drive a number of disease processes into remission. That's the magic. And I think that's the thing, that's the hope that people need to, I think, sort of walk away with. It's like, hey, diabetes is not your destiny. Neither is hypertension. You do those lifestyle things, you can drive those disease processes into remission to go back to a normal physiological state.
And these are the conversations that we need to be having. And welcome, Dr. Saul Bautista. I have been greatly inspired by seeing the work that you have been doing in your home state with lifestyle medicine. And I'm so thankful that you could join us today. First off, thank you, welcome. And can you introduce us to the idea of lifestyle medicine and why this is such a different approach to medicine than we are classically trained in?
Matt, thanks for having me. And again, similarly, very impressed with the work that you do. And thank you for being a communicator. I think many of us that do this work, we need someone to sort of get this information out there. And you've been doing this, and that is not easy work. So thanks to you, and thanks for having me. So yeah, let's get started. Let's find, what is lifestyle medicine? Most people that I encounter and most of my colleagues have never heard of that term. Lifestyle medicine is a medical specialty that focuses on 6 pillars: exercise, nutrition, sleep, stress management, the reduction of risky substances, and social connectedness, to not only treat, but also in select cases, reverse disease, as well as prevent disease. And really, that's what makes it different from, I guess, what you can call conventional medicine or traditional medicine, in that we typically just manage disease. Once you have a disease, we use either pharmacotherapy or a procedural intervention to try to manage the disease, but we never really focused on driving it into remission and bringing someone back to a normal physiological state. And I think that's the power of lifestyle medicine, and that's where really it's super beneficial.
I think that we kind of have this, we almost have this like magical view of what modern medicine is, right? Like if you ask somebody, do you want to go back to the year 1750 and have a physician trained in the early 18th century treating your disease? We can all kind of say, nah, the medicine wasn't modern medicine. Nobody wants to go have bloodletting or leeches or something. But it gives us this almost false sense of confidence that modern medicine can, in fact, reverse disease. Why is that not the case? Can you give us a couple examples of where the average American might say, yeah, medicine will take care of that if I get that disease, and it actually doesn't have the ability to take you back to a physiologically normal state?
I think, and this is where I think history is fascinating. I think what happened was that the nature of disease has changed. In the early 1900s, the leading causes of disease was really infectious disease. And with the advent of pharmacotherapy, specifically in antibiotics, this idea that here's this thing that's a magic bullet that will, that will cure this ailment that used to be, that really was the leading cause of mortality. And then also with other select processes, surgical interventions became life-saving. So for a number of congenital diseases, so, the classic story of like blue baby syndrome, right? And that you can create a shunt, and now someone can live beyond the age of a year. So I think the general public became sort of accustomed to these like miracles, because it really was extraordinary work. The challenge is that the nature of disease has changed, and now chronic disease is really secondary to dysfunction, like cardiometabolic dysfunction. And that's a product of really society that's man-made, and really when we look at disease, the sort of like equation that I came up for myself was that disease is a function of biology and society, that those are the two variables that create disease. Some of it is sort of genetic biological aberration that occurs, and some of it is just man-made. It's a product of something that we have done that creates a disruption in our biology, whether it be synthetic chemicals that we've created that then we know cause harm, whether it be changes in our food supply chain. These are the things that disrupt our biology. But the thing that is really cool is that social problems have social solutions, and those same things we can use to bring us back to a physiological state, to correct that aberration. And I can expand upon that in a little bit.
And that's one of the things that's so important and missed out on in modern medicine, is this exact concept that organisms are not just biology. When we talk about the product of a gene, it's extremely significant to talk about we call it the G by E, the gene crossed with the environment produces an output. And in the context of the environment that our bodies were adapted to, that our ancestors were adapted to before the modern era, the kind of environmental exposures were dramatically different. And you hit upon a few really, really critical ones that gave us this notion of the miracle of modern medicine. Things like injury and infection, things that happen from outside of our organism, were major causes of death. If you broke a limb and you couldn't hobble back to your people and you were out in the field hunting, you could very well die from something like a broken limb. If you had an infection early in childhood, this was a major cause of the shortened average life expectancy from birth, because people had infections early on in life. They had parasites. We have essentially gotten these external factors largely controlled. We feel like the modern miracle of medicine is all promising us this amazing magic bullet, but then with this disrupted, this mismatched environment, what kind of disease burden are we actually looking at in a modern population?
And the disease burden really is due to cardiometabolic disease. And I mean, we all know the leading cause of mortality in the United States is cardiovascular disease. And then other secondary causes are really due to complications of that. So you have high blood pressure, hypertension. That's now the leading cause of chronic kidney disease that results in end-stage renal disease. So now it's more than 50%. Same thing with diabetes. And diabetes, I think it's the seventh leading cause of mortality. And so, actually now with obesity, the AHA has sort of created this new syndrome. It's like it's like cardiovascular kidney metabolic syndrome, because they all sort of fall into one package, and they're all associated. And obesity is a large driver and large risk factor. And if you go above that, right, because we're talking about in terms of biology, but what are the societal factors that lead to these risk factors? And we know that physical inactivity is a big driver. There was actually a 2000 paper, and it was looking at what are the actual causes of death. And leading causes are food and physical activity, along with smoking, were really the leading causes of death. Because if you look at what are the disease causes, yeah, it's cardiovascular disease, cancer. Then you have kidney disease. So, but above that, it's like, no, these are the actual causes. So those are the things that we should be targeting, but we don't. We target the symptoms of those risk factors. And that's why we haven't really made any progress in this chronic disease epidemic. We have the highest expenditure per capita, but with the worst health outcomes amongst industrialized nations. Right? That doesn't make any sense.
And that should bother all of us. Like, we have the investment in healthcare costs. It's not that we're a country that simply says we're not spending any money. We're sinking a ton of our GDP into healthcare. But as you have pointed out, it's not healthcare. It is sick care. The model of healthcare in the US is, when I feel sick, when my life is disrupted by disease, I'm going to go to the doctor, and I'm going to pay for a service, and I'm going to try to get better. And of course, it doesn't work like that. But that's how the system is built. And this idea that contingency is important to medicine is something that is so easy. The disease categories that you just mentioned, when we think about, well, how should we fund and respond to these disease categories, we tend to think, well, let's see, how can we relieve the symptoms of hypertension? How can we relieve the symptoms of metabolic disease? We have billions of dollars of pharmaceutical investments into responding after people have these diseases. What you pointed out, like, hey, these diseases are contingent upon this gene by environment interaction that produces a bad food environment, a bad physical activity level. And what are some ways that we can start to say, hey, we recognize this contingency, let's do something about it and actually reduce that obvious impending chronic disease problem that ensues from that?
I always tell people that the what is simple. The why behind it is what's complex. So what we have to do is actually very easy. It's eat a predominantly whole food, plant-based eating pattern. It's physical activity. We should have at least 150 minutes of moderate to vigorous physical activity. Engage in some form of resistance training at least twice a week at a minimum. Social connectedness. Yeah, there's an epidemic of loneliness and social isolation in this country. So doing something like getting together with your friends or someone you care about once or twice a week, having a conversation, just the simple things that we really don't have to think about too much, have such a huge impact. And I think medically, for example, when we treat patients, we help patients to do those things. So, and I'll give you a very good example. At Ethos Primary Care, or Ethos Farm to Health, which is a nonprofit arm of the medical practice, we grow the food we quote unquote prescribe to the patients. So there's a doctor's farm market, patients will pick up the food. But we'll also have, as part of our clinic visit, it's like, hey, you're going to come into our teaching kitchen. We're going to show you how to prepare health promoting meals, how to make predominantly a plant-based meal, right? So that you can do it at home. Because for some patients, if you've never taught them how to do these things, it's like telling them, hey, go build a rocket. It's like, if no one's ever taught you how to exercise, how to engage in resistance training, calisthenics, telling them to go do that is like telling them to go build a rocket. And then modern healthcare gets upset when it's like, I've been telling the patient how to do this and they don't do it. They're not adherent. It's like, well, of course they're not going to be successful. You know, we haven't given them the skills and the tools to be successful. And not only that, but then we send them out to an environment that just is antithetical to them making those positive changes. I mean, if we're trying to change your eating habits, but then I send you back into an environment that has nothing but fast food, that you have to walk 4 miles to your closest supermarket to get a fresh vegetable, behavior wins. People are naturally going to be like, you know what? I know I'm trying to make this change, but I can just walk 2 minutes to go get the burger. And that'll, and it's hard. And it's hard. So healthcare requires a really radical shift. One, in the financial incentive. We need to financially incentivize more physicians to practice this way. But also physicians have to be greater advocates in helping to change their local municipal environment. So I think those are some of the opportunities. But I'm very optimistic that we can get there.
Oh man, we need that optimism, because that is a radically different way of practicing medicine. Like, I can't describe how many memories I cannot quantify how many times that I have been present in a patient encounter when the provider either doesn't incorporate the discussion about food culture, doesn't incorporate the discussion about nutritional value, doesn't incorporate the discussion about physical activity into the discussion of the patient's health. And it's not that it's the fault of the provider when the provider is also embedded in a system that gives them 15 or 20 minutes with a patient. And we see the data, we say, oh, you have this sort of impending metabolic crisis. Perhaps diabetes is starting. Try to eat healthy. Try to cut back on your sugar. And we have this sort of, little few second bullet point where we're kind of like, hey, I passed on some of this, try to get moving. But it is food is culture. Food has been human culture. It's literally in paleoanthropology. One of the main things that we study is food culture. We can track back tens of thousands of years and tell you when a culture ate mostly plant-based or when a culture had starchy carbohydrates introduced and what were the diseases that were associated. And food culture runs so deep that when you send your patient out and all you had time for was this 10-second part of a conversation where you said, and remember, try to eat healthy. We know that that doesn't produce the kind of shift. And I love what you mentioned, because you mentioned two very important components that this revolution cannot survive in the absence of both of these components. One, the provider has to be given time to actually discuss this and have the infrastructure. Like you guys have a teaching kitchen, like that is so fantastic. And then two, you have to have some kind of shift. And I love that you have the reality of actually saying, hey, this can't be fixed just by the provider or just by the patient, because that second component, the municipality has to start moving things in society in a direction that stuff like the basics of food availability are fairly distributed. Can you, for our viewers who are listeners who are perhaps not in a situation where there is no access to fresh, wholesome grocery options, can you tell us, in a urban environment in America today, what kind of challenge do our patients face in actually having something like a fresh plate of vegetables?
Well, there's multiple factors that can contribute to that. Yeah, in an urban environment, say you have the closest, I don't want to even call it supermarket, but here in the Northeast, we have these things called bodegas, where they're like little convenience stores where food products will be sold. If you walk, that may be your closest access point to food that may be available. The challenge with that for many people is that the majority of food that's sold in that space, it's really just ultra processed food. There isn't really much fresh food. There'll be maybe a small, tiny refrigerated section with some vegetables that really the quality isn't up to par, and it's very limited. And there's parts of the country where, here in the Northeast, where I think we're very privileged that we have a very robust public transportation system. You can hop on a bus and get to wherever you need to. But there are parts of the country where that is not the case. Again, public transportation runs infrequently. So for some people, just getting out to a space is a challenge. Also, economics is a factor. But let's talk about. But what I think we can talk about really is talk about the innovative solutions that people. Because a lot of people know the problems. But what are people doing to kind of solve some of these problems?
I think you would be surprised at how many people, both inside of healthcare and outside of healthcare, at least in certain parts of the U.S., like in the South, really don't. They have no idea when they're telling patients go and eat healthier grocery items. A lot of people really do have a profound unawareness of the problem of food deserts. Are there solutions? What kind of solutions are you guys finding?
I think human beings are incredibly resilient. And one of the things I've seen is, in particular in my community, it's like, all right, well, no one's going to come fix this problem for us. Let's figure it out. And people started here in my hometown. And we've seen this around the country, this idea of self-sufficiency. So people started to take empty lots. And obviously, with the permission of the city, there was this sort of like adopt the lot program where there was these sort of old, blighted, empty lots from buildings that were demolished, but now they're just sort of like these open, grassy plots. And so people would put in applications to like adopt them or lease them from the city for $1. And they started community gardens, and
Wow.
they started to grow food and just, grow it for themselves and just give it out for free to their neighbors. And some of these gardens, oh my gosh, they've done such an incredible job. I mean, it's remarkable. I wish I had a photo to show you. I mean, they become like these little oases. It becomes like this little natural oasis in the middle of like the hood. And I can say that because I grew up here in New Jersey. And one of those plots I can tell you here in the city, along with state help, they turned this 3-acre plot that I believe was the site of a school that was wrecked, and they turned it into an urban farm. It's a 3-acre.
Wow.
It's the largest urban farm here in New Jersey, and this urban farm now produces a lot of the produce that goes to a citywide farmers market that's curated here in the city by a local nonprofit called the Greater Newark Conservancy. And so these are some of the things that people have done. And not only are they providing produce, but for example, they're hosting cooking classes. They're putting like little recipes. Now, some of these local growers, they created this like local grow box where, again, all the produce, they put them into these boxes, and partnering with local businesses, now people can order a box and go pick it up at a business that's close to them. So they're using existing community assets, existing businesses as distribution points.
Wow.
So instead of having to create a whole new system or network, it's like, hey, let's use what already exists, right? Let's use these empty plots. Let's talk to local business owners and let us see if they'll let them be like distribution hubs. And this is how you can start to sort of create a local food system or drive changes in your local infrastructure. But those things are not easy. And it takes cooperation and collaboration. But those are some of the small examples. So I, as a physician, what I try to do is help these organizations through advocacy, either helping them to acquire grants, advocating on their behalf at a state level. So when it comes to state policy regarding the agriculture or farming, to support funding for these local growers. The other thing I do as a clinician is really provide technical support. I mean, they're trying to host food and nutrition classes, but we're asking a lot of them to, hey, we're going to ask you to grow the food. We're going to ask you to distribute it. We're going to ask you to do the classes. I think clinicians or health systems can partner with organizations and, hey, you know what? Our providers are going to do those classes in a community setting. And that could be very effective. Instead of what I would do in clinic with one patient in 15 minutes, you can do it with 20 people in an hour. Now you're reaching 15-minute visits with one patient. You only see 4 patients in an hour. You can see 20 patients in an hour, communicating nutrition information, helping a chef do a cooking class with people. And that's how you spark change. That's how you can start to really create broad impact as a clinician. But we have to sort of think about healthcare delivery a little differently in order to do that.
I love this because the math, the hard numbers, that how many patients receive benefit per hour, it always seems like this insurmountable problem that we can't quite conquer when it comes to the value of things like nutritional education, because you just can't teach something like that in a clinical setting rapidly to a lot of people. And this is such a fun, engaging solution to that. Can you tell us how much of this is really the work of motivated nonprofits? How much of it is from physicians? And have you received more support from the medical community than you expected, or have you received more pushback than you've expected?
A lot of this work, it's a combination of both. I think that you have a very, very small subset of highly motivated clinicians that took it upon themselves to change their style of practice. And you also have community members that and organizations that took it upon themselves. The challenge is that clinicians are not taught this way. Frankly, we really don't know. I think clinicians think they know more about nutrition and exercise and disease than what they really think. And
the secret is that it's really not a big part of our medical education. Sorry, guys.
Correct. So that's why we end up giving this canned advice. Oh, just like eat less sugar and just like eat healthier. But what does that really mean, right? And I'll give you a very good example. So, for example, with diabetes, people tend to think of it as like a sugar problem, and it's more about it's more an energy storage issue that's driven by adiposity. It's for type 2. Let me be specific here for type 2 diabetes specifically. It tends to be related to adiposity, and it's adiposity that's driving the insulin resistance.
And for our listeners, for our non-biomedical listeners, give us the clear cliff notes on the distinction and why that adiposity matters and not just today's sugar intake.
So adiposity or body fat is this, and to be very clear, this is sort of how I look at diabetes. So over time, we all have a natural set point, and it's like fat is not a bad thing. It's something that it's a form of storing energy that we've all evolved for moments of scarcity. Now, what's interesting is that different populations develop different set points. And if we look at the literature, it's very clear that Asian, Southeast Asian, and South American populations typically develop insulin resistance at what's called like normal BMI or lower. You don't have to have a large amount of adiposity to develop insulin resistance in those populations. So everybody has a different set point of how much body fat or how much energy can I store.
And to make it, and to add in a sort of an anthropological note there, the populations that are indigenous to North and South America, we know from paleoanthropology, we know from anthropological data, did not have a long history in their ancestors of exposure to the products of agriculture. These sort of readily available, long-term storable, carbohydrate dense foods that predominated in sort of many thousands of years of Middle Eastern and European cultures that became agricultural civilizations as far back as 9 to 12,000 years ago. That sort of agricultural shift and the ensuing genetic pressures, the environmental pressures that were present because of that long-term carbohydrate exposure, they were not present for the vast majority of the ancestry of the indigenous populations in the Americas. We know that, in fact, even the classical association of like maize crops with certain indigenous populations in the Americas, even that did not happen. That shift towards dependence on maize crops didn't happen for many civilizations. And it only happened in some civilizations in the Common Era. This is a profoundly recent agricultural domestication that happened here. And so this is it, when we talk about the gene by environment interactions that you're getting down to, the populational differences are not they're not statements about the culture or the habits of groups of people. They're more reflections on sort of the biological tolerances that the ancestors of certain populations have
Right.
simply become selected for and accustomed to. And the assumption that the products of agriculture, the wheats and the barleys and the oats, that these kinds of products are biologically compatible. These are literally environmental exposures that were completely absent in certain populations, ancestors, right up until almost the present time.
Correct. Correct. And it's fascinating because even and I'll get back to the original point, but like,
Sorry to divert you.
no. This is fantastic. And I love that you added that because it's important to provide that context. And even, and I can give you a very good example, even within sort of like my ethnic history. My family is of Dominican origin from the Dominican Republic. In a generation, that has a profound effect. I talk to my family all the time. What in America is known as a Dominican breakfast, which is plantains with fried cheese, fried salami, fried egg, fried onion, that wasn't consumed every day. Here in America, it's consumed every day that way. But in my parents' time, which was roughly 40 years ago, I asked my parents, I was like, hey, how often did you eat that way? It's like, oh, we ate that maybe once a week that way. Because like you didn't have eggs every day. You didn't have quote unquote salami already accessible. That was maybe consumed maybe once or twice a month. Right? So just being here in the United States has shifted culture. I mean, it's retained culture, but not in the way that it was in the country of origin.
And the math on that, this cannot be overstated. Like, it's like if somebody says, oh yeah, I had Coca-Cola growing up. And what they meant was once a month they'd go to town with a parent and they would get to taste a can of Coke or a bottle of Coke. Once a month Coke over a year is a couple 100 grams of sugar over a year. But in the present environment where we have this abundance of easily accessible, hyper sweetened foods, if you talk to somebody who drinks a Coke a day, that's 20,000 grams of sugar a year. And so when we say these sort of general descriptions of even traditional food exposures, it's profound. The sort of aggregate exposure is profoundly different when something that was an occasional food exposure becomes an everyday thing.
Correct. And so now that has implications for a population. And that's why we see the prevalence, and I'll use the Hispanic population as an example, that we see the prevalence of cardiometabolic disease, such a profound state within that population. Again, we see higher rates of diabetes, and there's multiple factors that contribute to that. But circling back to diabetes, so adiposity. So now we have this overabundance of food. People are consuming food in patterns that may not have been native to them, or even foods that are not native. And so now we're in a positive energy balance, storing more body fat. I tell people body fat and muscle, they're not just there for looks. They have metabolic consequences and there's this association that, for example, body fat will secrete these signaling molecules that are known as adipokines. Some of these adipokines have been implicated in disrupting cell signaling mechanisms that are associated with the signaling cascade for the insulin receptor. Right? So that's how we can start telling. We know that obesity drives insulin resistance. The question is how. And this is a potential mechanism. We also know that people who exercise and with a decrease in adiposity, it sort of corrects that disruption. Well, what's the relationship? In 2003, they discovered that skeletal muscle has secretory function, or that skeletal muscle will release peptides that act as quote unquote hormones, have a signaling, some sort of signaling function. Interestingly, a cascade that was sort of identified was that when we exercise, we release IL-6, the muscle-derived IL-6, that then will interact with intestinal L cells to drive release of GLP-1. GLP-1 is, guess what? It's the same thing as Ozempic. Well, Ozempic is the synthetic analog of GLP-1, right?
And of course, Ozempic is the all the rage, the super requested, the everybody coming into the office to ask for pharmaceutical attempts to replicate some of the benefits that we get naturally in this pathway, like lower adiposity.
Correct, right? We know that, and people haven't identified the exact mechanism as to how Ozempic sort of increases satiety and drives lipolysis exactly. But to your point, we know when we exercise, right, it drives lipolysis. Well, there's a number of mechanisms as to how it drives lipolysis. Some of these other exerkines or myokines directly act on adipose tissue. And I don't remember the exact molecule that's released that interacts with the adipocyte, so that starts to catalyze lipolysis. I'll send it to you later, or for your audience later. But yeah, so when we exercise, we release these myokines, and one of these myokines specifically drives release of endogenous GLP-1, the same molecule that we know has these positive beneficial effects that we've seen through Ozempic. So yeah, naturally, if you look at all the epidemiological studies, they'll say, oh yeah, people who exercise have improved insulin sensitivity, have better glucose homeostasis, they achieve lipolysis and adiposity reduction and weight loss. And there's all these positive benefits that then drives disease remission, and they sort of fix their diabetes. Same thing, Ozempic. You give someone Ozempic, it's like, oh, hey, we lowered their A1C. They're losing weight. They're getting better. It's like you're able to achieve the same thing.
Mind you, and the natural in the context to give it that like contingency context, in the context of muscle building activities, in the context of exercise, you're getting the full suite of benefits. You're getting the cardiovascular benefits. You're getting the elevated muscle mass. You're getting a number of circulatory benefits that are dependent on the use of these muscle groups that you cannot replicate pharmacologically. It's interesting because the benefit suite that you see from a pharmacological option like that, minus some of the side effects, plus some additional benefits, are what we would get if we could actually move our populations in the direction of gaining muscle mass and being physically active. But again, we're sending people out into the world where everything in the environment is telling them, hey, sit back and relax and have a really rich meal and a really sweet beverage and just chill and don't walk. And I mean, everything from the time we're little, we're running outside and someone gives you a bicycle and you're still sort of active, but then, hey, look, a motorized scooter. And then, hey, look, a car. And then we sit and we sit and we sit. How do we interact with the population? We've talked about food. We've talked about really incredible advances that you guys are making, teaching healthier, more nutritional food culture. How do we move the culture of American patients who are at every option offered a seat and a Coke and a TV show? How do we move all of us in the direction of moving more?
This is probably really going to be unpopular, but I think it starts with healthcare. Uh, it, it, it starts with us first. It starts with our knowledge base. And then I think it starts, that exact mechanism, everything I just explained to you. I can tell you, I think very few clinicians probably have that sort of understanding of what is the relationship between exercise and sort of like diabetes and impacting diabetes. So it starts with healthcare with our culture. How do we reward clinicians? If you've ever been on rounds, or if you've ever been, you'll have the attending that'll bring in the box of donuts, right? Or the pizza, we as a quote unquote healthcare system, it's more of a sick care system. We create an unhealthful culture amongst our practitioners. And the very first principle of lifestyle medicine, the very first physician competency is leadership, meaning that the clinician has to engage in the behaviors that they want the patients to replicate. And if you walk around the hospital, some of our attendings' BMIs are equivocal to their knowledge base. So meaning very large. I hate, and I know that is contentious. That's a contentious statement, but I bring it up because I think healthcare, we need to have a very strong and hard look in the mirror. And we really have to hold ourselves accountable because we like to, I think, place blame on the patients, on pharmaceutical companies, the environment, but it starts with us. And I think the sooner that we can start to change, I think that'll start to create a ripple effect around us.
And it really, when we see healthcare practitioners who do have a knowledge base that gives us a foundation for knowing to move, for knowing to eat healthy, or at the very least for knowing the impacts of what happens if we don't do those things. When our brothers and sisters in healthcare are facing the same sort of constraints, the high pressure work environments, the long work hours, the simple fact that readily available food in this country is so frequently profoundly unhealthy, metabolically disruptive, oversweetened, under fiber, everything you can possibly imagine. That level of intentionality, that level of pre-planning to escape from those environmental factors that can be overwhelming. If it can be overwhelming for healthcare providers, we should certainly empathize with how overwhelming that can be for our patients. And how do we create, is it a lack of knowledge? Is it the just bare reality that the environment is this unhealthy? What are we supposed to do about this?
It's multifactorial because I wish I could say it's as simple as just, it's a food environment. Obviously, finances play a role. I think healthcare institutions are not, at this point, financially incentivized to provide this type of care, or to think, at the institution that I trained, and I won't name it, but we had a Burger King there for the longest time, despite tons of advocacy saying, hey, this doesn't make sense. Why is there a Burger King? Oh, I probably shouldn't say, well, I'll be fine. They come after me, but we probably shouldn't have one of those in the hospital. The data is abundantly clear. Ultra processed fast food does not result in good health outcomes. So Why would we have one of those in a quote unquote healthcare institution? And despite all the advocacy, and the institution did not want to break the lease, even though they could have. And the reason was financial. I mean, how do you explain that? I am not trying to, in sort of modern vernacular terms, throw shade or slander, because we work really hard, and I think people in healthcare make a lot of sacrifices. But I think we do have to look at things for what they are, because if we're going to correct this problem, we really need to look at these things for what they are. And so I think,
and it's not that it's like some grand conspiracy, right? Like there is a reality, there is a statistical calculation, even among healthcare companies, even among insurance companies. When we look at a structured sort of single payer system like exists in most modern countries in the West, there is a long-term value to having long-term health improvement. There's a long-term investment payout to having the prevention of chronic disease, because in a single payer system, if I don't teach you, the patient, how to be healthy and avoid disease now, 25 years from now, when you are suffering the results of metabolic disease, the single payer government system or the single payer, have to pay for all of the very expensive care for your chronic health problem. Now, in a system where we have privatized healthcare, we can talk all day about whether this brings benefits, but there is a very real statistical difference in the risk assessment. Because if I'm an insurance company and I say, you're going to only be with me during the 6 years that you work for this employer. So if I decide not to pay for example, a nutritional education program for you, and you don't learn to eat healthy, and you get a disease 25 years from now that results in profound metabolic disease, that results in amputation or home health care, that's not going to be on my bill. You're not even going to be with my company. So why should I pick up the tab to train you if I'm just saving another company an expenditure later? I'm not saving myself an expenditure later. And that is a very, very, very big difference that has profound impacts on what the patient gets covered for.
Correct. And I love that you brought up a very salient point. Again, it's not a conspiracy theory. A lot of folks like to go down that rabbit hole. These are just realities. Right? And if I was a company, I'm going to do what I need to do to be financially viable. Right? And so it's, how do we create novel systems? And I think that's what clinicians today are trying to do, is to get very creative. And I'll give you an example. People are trying to move towards what we call community engaged lifestyle medicine. It's how do we use naturally existing assets that are community based, that are not costly. So for example, if we know that exercise is important, right? There are people who naturally gather that are part of a run group or walking club that just get together really to socialize, because that is their social outlet. And all they do is they gather and they move together. But they do so really because they enjoy each other's company. So that could be the intervention itself. It's like, hey, there's this fitness group, what do you call it? That's like 5 minutes from where you live. Hey, I want you to go there twice a week. If we start to form these sort of like relationships, like it's really reimagining healthcare outside of traditional norms. And how do we use assets that we probably haven't considered in the past and integrate them into the healthcare landscape? Because that's low cost. Like pre-fitness group that's in your community that you enjoy. Oh man, right? So and that's just like, so there's many examples, but how do we leverage these things to really redefine our system? And I love how you brought up single payer, because that's how do we finance this, right? And that's there's a
Yeah,
lot.
how do I get compensated? And I don't have a pharmaceutical rep asking me, can you please prescribe more jogging? We'd really like it if you prescribe more jogging, right?
Yeah, and people like to point the finger at pharma. I'm very clear that, yeah, I think pharmaceuticals are a good thing. I think they help a lot of people. They've helped my family. They've helped me. It's not, but it's how do we pick the right tool for the right patient at the right time? Right? And I think for too long, we've been over reliant. Literally in medicine, for some reason, we've decided we only have two tools, either pharmacotherapy or some sort of procedural intervention. And that's it. That's all that exists. And I think we need to move beyond that and really acknowledge that for chronic disease, the modern diseases that afflict people, that those things may not be the most appropriate tools or the most efficacious tools.
And when we have interventions, there really is a profound difference that we have to be honest with ourselves and our patients about. If you are way down in the disease process and you need symptomatic relief, man, we're in a much better situation because of pharmacotherapy than we would be in the absence of it. But there's this profoundly disturbing realization that happens to young people. At least it happened to me. When you are training in medicine, you realize how much of healthcare is, to use a car accident as a metaphor. If every single day you were to get into an ambulance and drive to the scene of a car accident and find that people were ejected from their vehicles, and you looked inside and you realized there were no seatbelts, and this kept happening day after day, year after year, and every time you get in your ambulance and every time you go to the scene of a crash, you see people ejected from their vehicles, you would want to do the right thing and you would want to get them in the ambulance and take them to the hospital and try to help save their life and their limb. But it would strike you as profoundly disturbing that these people didn't have a chance to buckle a seatbelt and prevent such a high cost, terrible, painful outcome. And that really is the experience of a lot of training in medicine. You realize, man, this disease process, there essentially was a seatbelt that wasn't buckled up years in advance to prevent the ejection from the vehicle, when a person could have been taught. The commonly cited number is, if we were in line with lifestyle factors like proper food, fiber, nutrition, physical activity, reduced chemical exposures, things like that, we know lifestyle factors could hypothetically prevent 80% of the chronic disease burden. And so if we're going to get into that car crash and we know it's coming, we should buckle our seatbelts and actually do what we need to do. So we're not just doing sick care. Sick care has its place, but we don't want to only do sick care when we can do better.
And what's so wonderful is that it's great for prevention, but it's also treatment. And I think that is the opportunity, the golden opportunity that medicine is missing out on. That, hey, most people, I think, don't understand. Yes, I do these things. I can prevent a lot of disease. The magic is that same thing you can use to drive a number of disease processes into remission. That's the magic. And I think that's the thing. That's the hope that people need to, I think, sort of walk away with, is like, hey, diabetes is not your destiny. Neither is hypertension. You do those lifestyle things, you can drive those disease processes into remission, and go back to a normal physiological state.
And these are the conversations that we need to be having with our patients, not just, hey, this is the disease process that will continue to absolutely destroy your life. And this is the next bad thing that happens, and the next bad thing that happens, and the next bad thing that happens. We need to bring that opportunity for remission and bring the education with it. And thank you so much for all the work you're doing. If you can tell us, where can interested people go to learn more, and also where can interested providers go to learn more about this very valuable approach to healthcare?
Well, fortunately, there is just how any other specialty has a professional medical society. You have the American College of Cardiology. Lifestyle medicine has a professional medical society known as the American College of Lifestyle Medicine. So I would encourage them, hey, either look up the American College of Lifestyle Medicine.
And some people in the audience, their minds just went boom, because yes, it is just like there is a society and a college for family medicine and pediatrics and surgery. There is for lifestyle medicine too.
Correct. It was actually founded in 2004. And as of 2017, there's an American Board of Lifestyle Medicine that certifies clinicians, and just how you have to take a board exam for family medicine, for internal medicine. Now there's a board certification for clinicians. And I think that that's very important, because when I started training, really, that didn't exist. You sort of had to teach yourself going to conferences and going into the scientific literature and kind of amassing all these things. And now it's been nice and neatly packaged into courses and board review course. And so, yeah, I highly encourage anyone who is interested in learning more just to visit the website, and they can get all the information that they need from there.
Awesome. Thank you so much. I appreciate everything that you have shared and the work that you're doing, and really demonstrating in a real urban environment in the US that this kind of dream scenario, this community-based approach to lifestyle medicine, to healthcare, to wellness is possible. Thank you so much for everything you're doing.
Thank you for having me, and thanks to you again for being that voice, for having a platform where you're disseminating this message and these ideas, because that's how change is affected. Again, a principle in lifestyle medicine, the very first step to enacting change is consciousness raising, and you are doing that for us. So thank you. Thanks to you.
Thank you so much, Dr. Bautista. Appreciate it. Have a great one.